I'm Dr. Samresh, working at Raghudeep Eye Hospital, Jaipur and Ahmedabad. And I'll be talking to you on the use of low parameters during cataract surgery, more so with the newer machines, the new phaco machines that are in the market, and how you can optimize this, use and optimize your surgery, optimize your machines to get the best outcomes by delivering the least possible damage to the patient's eyes. And with this, I want to highlight that, for us today, in today's date and time, there are two sorts of systems. One is a gravity-fed conventional system, which is what we've all trained on, and most practices even now use gravity-based infusions. And non-gravity based infusion systems. The first one, the original ones, were forced infusion or a fish pump, which was propagated and was used quite extensively a few years back. And now a newer system of surgery called the Centurion Vision system, which I've been enjoying for the past 5 or 6 years and has been there for quite a while, which uses a newer concept of what is known as active fluidics. And I think it's patented by Alcon. And so I think we're going to discuss how and why these fluid parameters are important and what impact they do on the eye actually. And why should we move from doing a surgery and finishing a cataract surgery to now looking at the finer nuances of looking at these parameters and trying to fine tune them. So this started with our institute back in 2010, where our group published, we looked at two parameters, the low parameters and the high parameters. And when we say high parameters, we mean few things. We mean a high bottle height. We mean a high aspiration flow rate of 40 cc or above, a high vacuum, because a high bottle height is going to get fluid into the eye. A high vacuum will get the fluid out of the ie, and an appropriate phacoemulsification power. So we defined a high parameter group and a low parameter group where we use significantly lower parameters. And we found out that if you use a high bottle height and significantly high parameters, you cause more corneal edemas and more anterior segment inflammation on the first postoperative day. And I think this is very simple to understand. If you cause more turbulence, you're obviously going to cause more blood barrier to break down, and thereby you're going to cause more inflammation. Then we went ahead, we also found out that, if we are using high parameter group, we actually, with higher flow rate and high bottle height, we increase the IOP of the patient inside the eye during the surgery to as high as about 85-90 millimeters of mercury. Now, if you increase the bottle height, the gravity is going to cause that much fluid to go inside. So again, it's very easy to understand why the IOP would go up. But if you have a high IOP in any eye, but more so in an eye which has pre-existing damage, like a myopic eye, or a guy with preoperative retinal detachments, or eye with glaucoma, it's going to cause significantly more inflammation, more edematous corneas, but also significantly more damaged eyes in terms of other segments, other parts of the eye, simply because you're pushing in more fluid in less time in the eye. So this is just to show you what we did. We actually put a transducer probe in the eye when we performed a surgery. Now this is the high parameter group. So notice the bottle height is 120, flow rate is set at 40, and the vacuum is set at 300. Now real time, the machine is monitoring the IOP, and notice how the graph goes up and down and fluctuates anywhere between 60 and 110. And this is the onslaught the eye is facing. There's so much turbulence happening inside the anterior chamber while phaco is being performed. And this was a study done well before the Centurion Vision system came. This was, about 12 years back, this study was done. And compare it to what we defined as a low parameter group, where we used the bottle height of about 75-80, a flow rate which was exactly half, about 20. Notice that the maximum IOP hit during this surgery was about 60 millimeters of mercury. But what is more important, that there was no fluctuations and there was no up and down in the graph, and the graph was a tranquil graph. And that led us to understand that maybe it's important to understand these parameters and try to step down on your foot pedal so as to not only give a good surgical performance, but also help these patients recover better in the post-operative phase. A far more tranquil environment. And this is just a comparative, putting side by side a high parameter group, and look at this graph here, and compare it with the low parameter group with an IOP of 60 and a bottle height, corresponding bottle height of about 80 centimeters, and compare it to the high parameter group, which is a flow rate of about 840 and a bottle height going up to as high as 120. Basics are basics. So we have to understand in terms of fluidics in phaco that input has to balance output, and that is how you control the entire surgery and prevent any surge and any complication during phacoemulsification. What is your input? In a gravity-fed system, it's a bottle height. And what is the output? The output is the flow rate, which determines how fast you pull out fluid from the eye. And there's obviously a component of wound leak. So you have to understand that it is not the phaco energy, it is not the vacuum which pulls the fluid out, but the flow rate which determines how fast you will pull the fluid out of the eye. We also try to understand what these high parameters would do in the back of the eye or in the posterior compartment of the eye. So this is just to orient you. This is a cadaveric eye where we dissected out the Berger space, which is the space between the posterior lens capsule and the anterior vitreous face. Once we cleaved the space between those two components, we filled up this entire cavity with triamcinolone, preservative-free triamcinolone, because we wanted a sono-opaque medium so that we could see these Berger space. Then when we put a phaco probe in the eye, we move from no irrigation to irrigation, which is foot position 0 to foot position 1. And notice how this entire complex moves front and back. When we raise the parameters to a high parameter, and notice how we increase the bottle height and subsequently we increase the flow rate to 40. When we go from foot position 0, the whole thing moves anteriorly, and the moment we hit irrigation, there is a huge trampolining, and this big pressure fluctuation tends to happen inside the cavity. And notice that at some point in time, the entire vitreous face, the anterior vitreous face ruptured. So anteriorly, if you look at through a microscope, the posterior capsule was intact, but the anterior vitreous face ruptured and the entire vitreous was stained by these triamcinolone particles because of the pocket being broken down. And this led us to understand a lot of times when we see inflammation happening in eyes post-operatively, inflammation happening in eyes which have diabetes, which have vein occlusions, and we find macular edema is progressing, it's probably because despite an anterior posterior capsule being intact, the broken down anterior vitreous face causes all that inflammation and prostaglandins to migrate posteriorly and eventually causes this breakdown of anterior and posterior compartmentalization. So it's very important that we monitor this IOP throughout the procedure and make sure we keep it under control. Active fluidics, the one that we have with these machines, new machines like Centurion now, help us do that. They allow customization of IOP and optimal delivery so that you have a very, very controlled environment. Just to show you, for those who haven't seen the machine, there is no more bottle over here, and notice how the bottle has gone inside the machine, and there's a bag pressure sensor which actively compensates and pushes fluid inside the anterior chamber. Another good thing with the machine is now you can calibrate the machine to the patient's eye level, and this patient's eye level becomes the 0 level, and everything else, even in a gravity fed surgery on a Centurion, which is an option, you can use this to calibrate the machine. So it gives you excellent control. And I'll just show you the same graph on active fluidics. Notice over here that if you've set the IOP at 32 and we are measuring it, the IOP is being maintained at 30 to 40 millimeters of mercury in the eye. More importantly, notice that when we are doing the quadrant removal or fragment removal for a dense cataract, and we've set the IOP to 40 and appropriately we've set the flow rate at 20, notice that it's an efficient cutting. Notice the chamber is extremely dead stable and the graph is right where it's supposed to be, and it's a very, very tranquil environment. If you look at a gravity fed system on the same machine, on an infinity vision system, notice the graph fluctuates. Every time you break the occlusion during a quadrant removal, you're going to cause an influx or surge of fluid inside the phaco probe. And that is, if you notice over here, and if you're a purist, you'll see that even the iris will flutter ever so slightly. And those are the chamber fluctuations that are visible on this graph over here. If you compare it to an active system, the active system is actively compensating and pushing fluid and avoiding any chamber collapse. So if you look at the same pupil margin again in this eye, you will notice that even when an IOP of 40, which corresponds to a bottle height of 50, there is absolutely no flutter in the eye. And you are taking out this nuclear fragment so smoothly from the eye without any problem whatsoever. When it comes to lens removal, we have to understand that there are synergistic and antagonistic factors. You know, your fragmentation and energy will try to push the nucleus away, when your aspiration will try to pull the nucleus back into the phaco probe. So again, just to show you, on a Centurion vision system with lower parameters, which means a bottle height of about, an IOP of 30, which corresponds to a bottle height of about 40, 42, a flow rate which is low at 20, and an appropriate vacuum. Notice when we pull the nuclear fragment in the center, not much manipulation is required. You don't even need the second instrument. You can just hold and push your foot pedal down, and the nucleus will proactively completely disappear into the phaco probe without you doing any manipulations whatsoever. And this is the beauty of good fluidics in any machine. When you're actually testing the grit of the machine, you want to see how much the machine can do without you trying to move a finger over there. And notice the second instrument is on a side and the phaco is completed so smoothly. We did a high-speed study where we put a high-speed camera and we recorded what actually happens when we're doing an emulsification of a fragment. And notice the second instrument is dead steady over there. The phaco probe, particularly the torsional delivery of energy, is so good that it completely shears off the nuclear fragment, and there's a sort of a turbulent movement where the whole nuclear fragment sort of breaks down on its own without any second instrument maneuver and is completely absorbed. I'm just going to finish off with a case over here showing you how a dense cataract emulsification is, we all know it's a challenge for us. We all know that division is the biggest challenge. Removal is the second biggest problem. We use various techniques. We use direct chop or modified stop and chop techniques. I'm just going to show this lady, 78-year-old, with a post-P. I will show you. This is a classical black cataract. It's not a good cataract for anybody, however senior the surgeon may be. But this is where you test the machine to its real capacity. Notice that I have a phaco tip which is slightly more exposed than normal because I like to bury it right in the core when I'm chopping it, because I like to see the tip disappear so that I know that there's a good hold on the nuclear material. I am chopping a dense black cataract with a vacuum of 600 plus, but my IOP is only 40 and my flow rate is only 20. And notice there is such a good hold that I'm able to complete the entire chop. Sometimes you may not be able to do that, and what I normally would do is bury the probe at a deeper plane on the same area and go ahead and complete the chop over there. Notice over here that this is a good classical example of a direct chop that was possible due to two things. One, excellent chamber control. There was no post-occlusion surge, which is a classical problem when you're chopping a dense cataract. The moment your occlusion breaks, your entire chamber tends to collapse, which is not what happened. And we also use the multi-level chop technique to a great advantage to be able to divide the base plate, because until you divide the plate in a black cataract, it's highly unlikely you'll be able to take out the cataract quite intelligently in a better fashion. We published this multi-level chop technique again, and I'm not going to dwell over this because it's not the point of concern today. But once you've chopped the nucleus, fragment removal becomes the next big challenge, because in a black cataract, fragment removal can cause surges to happen during the surgery. And again, this is to highlight how you can play with lower fluidics. If you have your input and output, and it doesn't really work with Sejurin, but it will work with any good machine. First and foremost, basics are basics, and please use dispersive viscoelastics to prevent damage to the corneal endothelium. But notice over here how my IOP is set, or my bottle height is low at 40-50. I'm using a flow rate of 20. Vacuum, I'm using appropriately around 300 to 50 vacuum. And I'm using a good amount of energy, a torsional energy of about a 70. And if you have a dense cataract, it's a great idea to avoid coring into the nuclear material and to divide this. Once you've caught it, notice how I'm using my second instrument to just ever so slightly nudge this fragment away from the eye, from the phaco probe, so that there's no complete occlusion. And with good torsional energy, you are able to emulsify this lens completely and it disappears. And this is just to show you that if you use your parameters right, post-operatively, you can have really nice, good, clean corneas, and you really don't have to worry about good outcomes. Just to finish off, even not only the dense cataracts, but even in a soft cataract, this is a post RKI. This is an RKI with a high myopia. Notice that we are, I'm using a 4-quadrant technique in this because it's soft cataract. But my bottle height, if it were to be bottle height, would be about a 30. My flow rate is set to 10 right now, and it's gone to 20 because of fragment removal. But even at an IOP of 20, which is a bottle height of about 30 to 40, notice how, because of active fluidics, the chamber is so stable. Because these myopic eyes are the ones where you will see the entire chamber collapse and the pupil go in and out. But even in these eyes, notice that there is such a good tranquil environment. The other one very important reason why I don't want a high IOP or a high bottle height, and particularly with RK eyes, is these RK incisions might open up like a zipper, which is something all surgeons would have seen, who has operated RK, that there is no predictability to these incisions. But if you can keep the IOP low, or if you keep the globe less inflated, chances are that your incisions will not open up during the surgery. I tend to use a bimanual for my cortical removal. And again, if you notice in a bimanual, I keep the bottle height low or an IOP low, and we are able to finish off the surgery with an elegant fashion because we were able to control the fluidity. So I don't think it's right to say one formula works for all. One has to understand that fluid parameters are very dynamic. You have to understand your machine and use the fluid parameters. Try to go low because you might take a little longer to finish the surgery, but the post-operative outcomes and long-term outcomes in terms of endothelial loss are lesser. It gives you far more ergonomic comfort, especially for early surgeons, because they don't know how things are happening. So, while senior surgeons can get away because they've learned with experience, early surgeons should go slow on their machines. And of course, with these newer machines, there is so much more greater safety, and like I was saying in Dr. Naren's talk, it's the early surgeon who needs to adopt a better machine because that will make the surgeries far more predictable. So good surgeons and experienced and veterans can do away with even poorer machines. But I guess if you can have an access to a good platform and good knowledge on this, it will go ahead and saving all cataracts for everyone. Thank you.
Wonderful presentation, Dr. Samresh. I mean, really enjoyed your videos and all. Is it okay if I can ask you a question?
Sure, please.
Yeah. So, I mean, if you can just tell a few instances at like what type of cataract or what kind of situation would you, I mean, where operating at a lower IOP is really beneficial?
So I think that's a great question. I think for me, my IOP is set at 40. So even for any cataract, I don't go beyond 40. Because now with Infinity, my bottle height was set at 80 for fragment removal, but I am getting away with an IOP of 40 for all my cataracts because the Centurion is pushing in fluid and keeping the chamber stable. If I have a myopic eye, or if I have an eye which has a tendency towards floppy iris, I tend to drop down my IOP from 40 to say 30, and I will finish my entire surgery at 30 IOP. But I appropriately also reduce my flow rate in these eyes to go slow so that there's no turbulence in the eye. But 40 is my upper limit. So I haven't even tested the machine above 40 ever since I have it.
That's fantastic. I totally second everything you just said. I think in terms of phaco machines, I don't think so. Alcon has competition right now. As of now, I mean, no matter what kind of cataract, what kind of like bad situation, you can really get away if you're very sloppy on that day also, because the machine does most of the thinking and most of the correction. And and especially even with so we have the active centric handpiece added to the active fluidics. I mean now I'm like every time 20, that's it, it's fixed 20, and then my vacuum is 600 60 flow. I mean, it's an amazing machine. I would just like to add one more point is, I think even in posterior polar cataract, I feel it's really good thing, because it's very important to have very controlled chamber, because any kind of snap can easily open up the posterior capsule. I feel this really works well in these kinds. And also one point is the patient. I mean, patient really enjoys it, because especially like you said in myopes, suddenly, the chamber, because of the reverse pupillary block, the chamber deepens, immediately patient just jumps out of the bed. I think this is a beautiful tool where the patient doesn't feel whether a machine is entered into his eye, because you're just meeting the normal IOP of his eye. You enter, you finish, and you come out. So the patient just, every time he asks me, is it done? I mean, like, wow, fantastic. So I feel that's really the big plus point between, of this acticentric and anticentric handpiece. Definitely.
I think a great point, Dr. Naren. For any cataract, trampolining is not a good idea. So you have polar particularly, because polars, I encourage all the junior surgeons any listening to at least do a sort of viscoelastic exchange to maintain the chamber. But if you can get away without any fluctuations whatsoever, it's probably a miraculous surgery. And like you said, it's a no-brainer. So, if I have to go to another machine, like Dr. Naren said, he's operating at 600 vacuum, which is an insanely high vacuum for, any other machine. And if you do a 600 vacuum with a 50 bottle height, you are 110% going to rupture your posterior capsule if you're not an experienced surgeon. But with this, you don't have to think about it. It's like, you can be doing something else in your mind. You can be discussing something else with your assistant, and you will still finish the surgery, and you will not even feel that slightest flutter in the eye. I think it's brilliant. One more thing that I learned, particularly with myopic eyes, and the fact that you said when the whole thing moves posterior, there's pain which bothers the patient completely, is I normally ask my assistant to drop down the IOP to say 20 when I put my irrigation in the eye, and then ask him to slowly build it up. So that slow build up causes the ciliary body tension to build up slow, and the pain is, I think, a little more tolerable. Which I think even for a gravity fed system, you can start at a bottle height of 30, enter, and ask your assistant to raise the bottle height to 80, and the patient will bear it better.
I think that's a very good point. Actually, the Alcon system has built in this feature. Doesn't matter which IOP you have, it's got this IOP ramp. So like even if you have a higher, slowly it increases. But that's a very good important tip, which if you're not operating on Alcon or active-centric handpiece, you can just do this. One more simple tip is, let's say, okay, now you've filled the chamber, you have finished your X's, you're about to take your phaco machine inside. So you take a phaco machine inside without pressing irrigation first, okay? Then what you can do is take your dialer, just lift the iris a little bit, and then turn on the irrigation. So this way, you really prevent any kind of a reverse pupillary block and then the chamber deepening. This is also one small tip which
I think that's a great point. And these small things matter. At the end of the day, you will realize that small things will make the surgery good for the patient or the experience horrible for the patient. And that I think is a great. Slowly start paying attention to small details. So if I think Dr. Ramamurthy sir hasn't joined, is Dr. Haripriya madam here? Has she joined?
Yeah, both of us are joining shortly, sir. So we may continue our discussion, no problem.
All right. So I think in that case, I think it gives us an opportunity to discuss, a lot of these. So how do you find just between? Okay, before I forget, I wanted to bring about these subtle points. When I hear a lot of these doctors saying that a lot of these companies have marketing things where they have a remote for control of the machine and all that. But again, it's so important, because if you have so much control for a surgeon who's operating, building up that IOP RAM, like you said, or building up the bottle height, even with the remote, is a slow controlled fashion compared to a normal machine. So even subtle points are very, very important when you come down to the quality of surgery that a patient experiences. What's your take,
Right.
Dr. Naren?
No, definitely, I would agree. See, that's what I keep feeling, that we are, I think, are spoiling our fellows, because they keep operating on these machines, and when they go out, they go outside. I mean, it's not a pretty picture. So I feel, I don't know whether it's a good thing or bad thing, but I mean, sometimes, always, if you have the opportunity, make sure you operate on all. When I was learning, I mean, I used to operate, I should not be picky, because I mean, if I wanted to, I could have chosen what machine I want, but I should just leave it randomly. Whatever machine is ready, which is free, I just get into that OT and try to operate. It's very important to not get used to one thing, just to keep your you should be on your toes, so that you're more alert, because these kind of machines really spoil you, because most of the time you'll start daydreaming then when you're doing a surgery. So you don't realize how you finished the surgery.
And with things becoming so seamless, with the Centurion Vision system integrating to the femto cataract, integrating to your Varion system, there's literally a seamless flow of knowledge that's happening between the machines. And so you become a little